Good afternoon, ladies and gentlemen. Warm welcome to all of you to another edition of APAC Dialogue. Very briefly, APAC News Network is a media organization headquartered out of Noida with a pan India presence and presence across other Asian regions like Singapore, Malaysia, and Dubai. Primarily, we focus on technology deployment across government, healthcare, education, BFSI, and other enterprise segments. So today we have with us as an eminent guest one of the top healthcare leaders of the country, Dr. Shuchin Bajaj, founder director of Ujala Cygnus Hospital. So welcome to the show, Dr. Bajaj.
Thank you, sir. Thank you for having me.
So maybe without further ado, we would like to start the discussion, and maybe the best way to start would be if you can take us briefly through the operational model of Ujala Cygnus Hospital and what role technology plays in that operation.
So the operational model of Ujala Cygnus developed because of certain constraints and makes just reinforces the faith that you operate the best when you have the maximum constraints around you. Because the current generation always wants to have freedom, and we love the freedom that we have. We can't work with so many restrictions, but I feel that having no constraints at all leads to a lot of inefficiencies creeping into your operations. So we started because we had no money. Very frankly, we come from a very resource constrained background, so started with a very small clinic, and that clinic's budgets would be like, oh, can we buy a glucometer this month, because so many diabetics come to us and we need to get their blood sugars on a real time basis instead of writing them a test and saying you get it done in your lab. But at the same time, a lot of asthmatics and COPD patients also come to us, so we should have a nebulizer also, because that's quite life saving. And we, but we can't afford to buy both in the same month, because the nebulizer is 1500 and a glucometer is 1100. So let's go for the glucometer. We'll buy the nebulizer next month. So these were the kinds of budgets we started out with, and of course, uh, as luck would have it, things happened and on the way, and now we have 16 hospitals spread across North India, still catering to the most economically challenged and geographically challenged communities, of course. But since we had no money to start with, the economic model is still very lean, very efficient. So we don't own any land and building, because in the early days we didn't have any money to buy the land and building. So we started out on rent, and we still are on rent everywhere. So we just lease out buildings, we lease out pre-existing hospitals or hotels or malls, and then try them, convert them into hospitals. Our setup costs are very, very lean. Uh, we set up fully equipped NABH accredited hospitals with equipment, plant, and machinery at par with any other big hospital that you would see in the city. I mean, we have the same cath labs, modular OTs, dialysis machines, neurosurgical setup. I mean, whatever you can speak of in a tertiary level hospital, we do everything. But the setup costs are approximately about 10% of a similar NABH accredited hospital with similar facilities. So the return on capital is assured to the investors, because we work in small towns with very geographically challenged communities and economically challenged communities. So technology has to, of course, play a very immense role in this, because there is no efficiency without technology. So we take the help of technology to substitute as many human functions as we can. The simplest part would be, say, reporting of a CT scan, which can be done technologically very easily. Even a simple thing like an ECG. So I remember in my very early days, I remember being woken up at 3 a.m. saying a patient has come up with chest pain. He's very anxious. So I'm driving at 3 o'clock from my house to the hospital, and I go there and see the ECG is absolutely normal. Patient is fine. And it's just maybe a bout of acidity. So we don't subject our consultants to these torches anymore, because we can transmit the ECG picture very very quickly to the consultant to see, to the cardiologist to see whether it's okay or not. So we have all our supply chains on the cloud, so it's very visible, very transparent. We know the cogs of cogs, we know the suppliers of suppliers. So supply chain efficiencies are very very deeply built into the technology. Then of course, keeping in touch with the patients is very important, especially if you want to reduce their cost of disease. Because if you don't keep in touch with your patients and then they get complicated, they don't control their blood sugars, for example, at home, and when they reach you, they're already in kidney failure or they've developed diabetic foot or etc., so their costs of the disease are very high. So keeping in touch with the patients is something that we use technology a lot to do: teleconsultations, digital health, all the records available at the click of a button. So clinical, paraclinical, non-clinical, managerial, supply chains, all of it is deeply and innately technology enabled, because without it, I don't think we'll be able to operate this large network of hospitals, clinics, and digital health that we run across North India.
Thank you. Thank you. So this brings us to the immediately the question, as you mentioned, and obviously, your focus has been significantly on the economically more challenged section, and so that in turn means you have to keep the hospital charges to the lowest minimum possible. Now, when you are leveraging technology, as you mentioned, across clinical, non clinical, supply chain, across all the facets of a hospital operation, uh, so at the same time, how do you sort of um, ensure that the costs are kept down so that the expenses of the technology are not passed on to the patients?
Yeah, so we work on volumes of scale. So we have various models to keep the cost down. One is, of course, scale. One is keeping our costs on as much of a fixed basis as possible, so we don't incur any variable costs. So once the revenues crosses a certain Rubicon, it then most of it starts to flow into the bottom line, because there are no variable costs to the ever increasing revenue. So if we can get a certain number of patients and a certain number of procedures, and beyond that we can do almost everything for free, and so that is where we earn our money. Of course, we lose money if we don't get patients, because the costs are so low that a lower number of patients is not enough. And as I said, technology is something that we use very heavily. So and we use locally available technology, free to use technology. We still don't have an ERP or a software custom built for us yet. So we try and take things as much off the shelf and customize it according to our needs and tweak it a little bit, so that we don't buy very expensive technologies to work with us. So everything is looked at through an efficiency lens. Everything is looked at through volumes lens. Everything is looked at through how much of a difference we can make to the community and to our patients by bringing these innovations and steps towards more efficiency. So the 80-20 rule is a very good rule to follow. So we find out that we can do more than 80% of the things at just 20% of the costs, and it's only the very high level 20% of the things that really need high end machinery and high end equipment. So this is something that we follow very rigorously, that can we treat so many number of patients with these interventions and technologies, rather than just targeting a very niche segment of high paying low volume patients. So everything is looked at through all these lenses. And finally, of course, the lens that we look at is whether all this is leading to our one main purpose of patient delight, patient satisfaction, saving a patient's lives, and making sure that the patients have both very good outcomes, not just good physical outcome. That of course is a sine qua non. We have to do it. We can't have bad physical outcomes coming to patients, then of course no patients would come to us. But we also try and make sure that the patient has very good financial outcomes. It shouldn't be that we've saved his life and then he has to sell his house and his fields and his land to pay for our bills, and then once he gets out of the hospital he has nothing to do but beg on the street. So we make sure that patients have both physical as well as financial outcomes which are very favorable to them and their families.
That's very nice to know about that. Another challenge here, when you are involving again all the stakeholders. So typically in a hospital ecosystem, you will have the doctors and the nurses who are the caregivers. You will have the administration people. You will have the suppliers. So all these are part of the ecosystem, and now this extensive usage of technology, and at the same time you are saying you have to sort of ensure the efficiency out of it. uh, how is the coordination or the integration between each of those stakeholders in the ecosystem as far as technology usage is concerned?
So, in my very early days, we found that whatever technology we tried to apply, since cost was a big part of it, so we would end up getting the cheapest ones on board, and the decision makers in buying that technology would unfortunately never be the clinicians, the nurses who would be getting to use it. So the decision would be made by us because we were writing the checks, and then our IT team and our finance team and our operations team. So these would be the people who would be deciding, okay, we should get this software, and we should get this technology in place. And then about 3 months after using it, we'll get feedbacks in, and the feedback from this team that had made the decision was very different from the team that was now actually using it on the floor. So the IT person, the finance person, the directors, they would say, "Oh, this is very good, very good, very good." Everything was very good, very good, very good. And then when you start opening the nurses' feedback and read it, like, it's horrible, very bad, too time consuming. We can't work on it. We don't understand half of it. So it was like an eye opener to us that all this talk about design thinking and empathy with the end user and stakeholder, it's not just managerial talk. It is like really, really very important to be on the ground, to do Gemba all the time, make sure that the end user is the one that does the final trials and make sure that everything is in place before you close that order. So that is something that we learned very early on in our journey, and now all the decisions about new technologies getting in place are made only when a large sample of the end users try it out firsthand, and they walk the teams through that entire journey of taking that technology, customizing it, making little changes, tweaking it up, so that finally they also feel that they're a part of it. It is their baby. They've made all the decisions. They've made these changes, so they make this extra effort to go and adopt these technologies, because obviously change management is a difficult thing. Whenever you do something new, there will be resistance to it. But if, as long as you bring enough stakeholders in a very early stage of that journey, instead of making that decision and just handing over to them that, okay, this is the new stuff, you get to use it now, from tomorrow go ahead, then of course the resistance is much higher. But if you bring them on board earlier, make them a part of the journey, make them decide on things, make them feel like that they are the ones who've been the main decision makers behind adopting it, then they of course will make the bigger efforts to make sure that it is a success.
Obvious. And maybe looking back at the last couple of years during the pandemic time, we know the situations were not normal, and unless unless for the emergency requirements, even a lot of cases, patients were hesitant in coming to hospitals. But the emergency things had to go on, obviously. So, how did one overall your operation? How did you manage the operation? And second, what was the help provided by technology in running during these times?
So COVID was a eye opener for us in more ways than one. As famously Reid Hoffman had said that entrepreneurs are people who jump off a cliff and then start building the aircraft on the way down and try to fly that. In COVID, actually, we were pushed off that cliff. We didn't choose to jump ourselves. We just had suddenly the ground was, completely gone from beneath our feet. And unlike other businesses, I'm not saying anybody had a good time there. Everybody had a hard time, but especially hospitals, unlike other businesses, we did not have the option of closing down or working from home or you know uh, downsizing or choosing not to pay our rentals, because we were at full strength. We were completely ready for the supposed wave of patients that was supposed to come in, which never came in the first wave. The first wave was exactly like the third wave, even I think even lighter than the third wave, because in third wave at least you had a lot of patients having COVID positive and sick at home. But in the first wave, due to the intense and strict lockdowns very early on, the number of patients were very low, and there was no streaming in of patients into hospitals. So all the hospitals were completely empty. There were no OPDs, no elective surgeries, wards are empty. People are afraid of coming to the hospitals. They're having these strict lockdowns. So we realized very quickly that we were now losing touch with the community, because the community was unable to access us. They were not able to come to us. And we started a telehealth solution, I think just 2 days into that lockdown, within 2 to 3 days. And due to that strict lockdown at the peak, we were doing almost 35,000 teleconsults a month with that time. We also got time because we were too busy before that in the daily scut work, daily firefighting, intense operations. So during that time, we got time to reimagine and restudy our supply chains, make them more efficient, finding new suppliers, going to suppliers that were higher on in the chain rather than the lower people who had lower margins to offer to us. So we made efficiencies an intrinsic part of our supply chains. That was something that was very good at that time. We also learned that we had more capabilities than we could imagine. So we were not cognizant of our capabilities. So when the second wave came, it was actually quite horrible, one of the darkest times that I've ever seen in my life. And you know what had happened in North India during the second wave. It was like hospitals were brimming over. We had ambulances lined up almost almost a kilometer and a half away from our hospitals, just lined up to take patients in. We had no beds, no oxygen. Things were in short supply. So we opened a 1,000 bed completely free of cost uh, hospital in Delhi in partnership with the government of Delhi in Buradi, and that we opened within 7 days. So we started conversation on a Monday that we need more beds, and people were not finding it very difficult to have beds. And on the next Sunday, we had opened the hospital and brought in the first patient, and that was completely technology enabled, completely paperless center. There was no paper there at all. Everything was on tablets, and even the booking of patients, everything was done online. And we had 308 ICU beds there, fully equipped with ventilators and oxygen. It is still the largest field ICU in the country with 308 ICU beds. So that we opened very quickly. So led to some belief in our capabilities. We also opened a 100-bed COVID hospital completely free of cost for patients in Prayagraj, in partnership with the government of Uttar Pradesh and Bill and Melinda Gates Foundation and Give India Foundation. So a lot of things during those COVID times that we learned, we applied on the ground. We implemented a lot of newer things and learned a lot from them. Seeing the success of our telemedicine program in the first wave, we launched a completely new vertical of digital health in the second wave. and it is now a large organization with more than 55 people working for it, and that is doing about more than 10-12,000 teleconsults a month, which are completely free of cost again. And it's called Medfo, short for medicines on phone. It's a full separate organization now working on digital health from the learnings that we had. We also launched a not for profit voluntary organization in partnership with many other techies and founders, which started off as a small WhatsApp group called Founders versus COVID, and now it is called Project Step One. We worked with more than 21 state governments during the COVID times. We had more than 12,000 doctors volunteering on that helpline at one time, and we did more than 10 million teleconsultations and calls with COVID patients during the last 2 years, completely free of cost for both the patients as well as the governments. So that those were some things that we used a lot of technology for. The Project Step1 was like a new marketplace for doctors and patients, just like Uber is. So, which connects people with cars and people who want to travel in cars. So it was completely on your cell phone. You didn't need any call center or any office, any organization. It's still an office-less organization. There is no office, completely virtual. I mean, no office bearers. Everybody is a volunteer, and we met some of the volunteers for the first time, people who were working in the core team. We met them for the first time after COVID, when governments were calling us to felicitate us. So we were called by the Puducherry government on the Republic Day felicitation ceremony. So three core team members were there to receive that award, and all of us were meeting everyone else for the first time in our lives. So that was something that is truly technology. I mean, you could never have done it earlier. I think it was unbelievable that we had worked for 2 years, done 10 million teleconsultations, and there we were meeting each other for the first time in our lives. So that was something that was very exciting and very new in our lives. Yeah.
Thanks. That sounds so interesting. So this telehealth part, so typically we have seen see, the telemedicine would require a lot of regulatory compliances also, especially on the medical legal front. And this was, I think, around when the lockdown happened during the first phase when the telemedicine guidelines also from the government came up. So one part of the question is, and since as you mentioned, even the other operation that you launched was completely on this telehealth part. How far is this medical legal compliances managed? That is one part of the question, and the second part of the question is, again, as you mentioned, a large part of your patients you are addressing from a relatively economically weaker section, and some of them might not be that much tech savvy. So when they are undergoing treatment through telehealth, how do you ensure that they are able to manage?
Yeah, in fact, when we started Project Step One, teleconsultation and telemedicine was still illegal in India. So it was completely illegal to offer any sort of medical advice on the phone. But yeah, we knew that this wave was coming. It would overwhelm a lot of governments and a lot of doctors, and there was no way that we could have managed it through just a physical infrastructure. So that is how we started it, and fortunately, only 20 days later, the government did bring out the telemedicine guidelines, as you say, and we had a lot of clarity on what could be done, what not to be done. And we do a lot of trainings for all our doctors and nurses and paramedics on exactly what is possible, what is not possible. So like when we did launch Medfo, it is completely digital and telehealth focused, so it's a separate organization altogether. And we do realize that the culture of the new age digital companies is very different from what we have as a brick and mortar company. So Adding four computers to Ujala Cygnus does not make it a Practo or a Pristine, right? Those are like two very different animals. So we understood that it's not that we just add four computers and bring in some people and we'll have a digital organization built. So that is a different culture altogether. They have a different office, they have different business leader, they have a different team completely. So we make sure that we don't interfere with them too much. So they do their own trainings. They have a lot of doctors on board, and they do a lot of trainings for the doctors to make sure that they're legally compliant, they're ethically compliant. Ethics is something that is quite non-negotiable to us. We lay a lot of emphasis on ethics, on making sure that we do the right thing for the patient, and nothing is done for financial reasons per se. Finance is, of course, something that is a side reward to what you do. If you are working hard enough, finances will automatically follow. But the ethos of the organization is not to do things to prepare Excel sheets or quarterly reports. In fact, in our organization, it's a fireable offense if you turn back any patient due to just pure financial reasons, that this patient did not have money, so we did not treat him. If someone says that, there is a no questions asked firing policy, that you may have been a star but you do not fit into the culture of what we do. So lots of trainings, lots of repeated empathy, lots of cultural ingredient into the people who are working with us, our colleagues, our co-workers, our families. It takes a lot of effort, but of course, at the end of it, everything is worth it.
Definitely. That's always there. Another part I would like to understand, you mentioned earlier the functional units, the doctors and nurses, and how they reacted to this different technology adoption. Now, even technology, we can say typically in a hospital will be two kinds. One will be the medical technology itself, the equipments, devices, and other technologies, and then there is a IT technology, IT part also. So overall, to manage this internally, again, as you also mentioned that you are running a lean function and you have 16 network hospitals now. So how is the team structured to handle both the medical technology and the IT part? Apart from the users, users are the doctors and nurses, obviously. But how is the team structured there?
So, as with everything else, the team is also very lean. All our operations are very lean just because we don't have much money to fatten up ourselves. The team is very lean to manage these 16 hospitals and multiple outreach clinics around these hospitals, multiple free dialysis centers that we do, and the two government hospitals that we run, the 1000 bed Buradi Hospital and the 100 bed Prayagraj Hospital. All this is managed. At the top is a very, very small corporate office we have. Less than 25 people work here. So, where I'm sitting right now. It's a very lean office, and we have a board of directors at the top. And this board of directors, one of us sees the operations on a day-to-day basis. One of us sees marketing, investor relations, digital, pharmacies, etc., supply chains, and one of us oversees the finance and HR functions, which are the most important, I think, in our organization. So this is we have a small second lab, that we have a chief of operations, we have a chief of marketing and sales, and we have a chief of HR, who are the second line, that and the chief of finance, of course. So the four people who are part of the second line. And then to the chief of operations, we have the head of information technology reporting to him, who handles all the digital functions on the hospital side, as well as the incorporation of new technology. And To supplement his functions, of course, we have a very large digital team now, which I said is headed by a CEO of Medfo, Shashank, and he has more than 55 people working for him now in a separate office completely. They work on a arm's length basis with us. They can provide digital help to any organization, provided it is comfortable to them and rewarding enough to them. But they also help us a lot in our digital strategies, in digital patient acquisitions, in keeping in touch with the patients through their entire journey, from discovery to post discharge and follow ups. So the organization, as I said, is very lean. We don't have too many people. Each hospital has their own IT heads and digital heads. So two people in each hospital. Sometimes we have only one person duplicating both the roles. So not many people to take care of everything in this, but as I said, it's technology enabled, so we rely on technology to support us and give us all the features that we hope to replace humans with.
Okay. And how is this, since this telehealth and the remote care part now, I won't say it has gone away, but the COVID is has subsided. So how, and things are turning back to normal. So how do you see the response now towards telehealth and remote care? That also came up in a big way during the pandemic. So how are things now?
So I think the behavior change has been very sticky and it's not going away very quickly. So we had almost zero teleconsults before COVID, but as I said, at the peak, we were doing about 35,000 teleconsults a month. We are still doing about 15,000 teleconsults a month. So from zero pre-COVID to 15,000 a month, and we are looking to increase this to almost 50,000 a month in the next 6 months. So the behavior change is very sticky. People don't want to travel for a day, come down from the hills to the hospital, spend a full day hiring a jeep and coming and talking to the doctor just because their blood sugar is now 250 instead of 150 that was earlier. So they would rather call, and they have been informally doing it. India has a large example of people who just pick up their phones and call the doctor, that doctor, I'm feeling this, I'm having this trouble, can you help me? So many people do that, but now it has been formalized and institutionalized as a teleconsult, and we see a lot of it happening. As I said, supply chains that we used to do manually quite a lot earlier, everything has been digitized, so that behavior change has stuck with us. A lot of tele-reporting, etc. The remote care that we used to have in homes, that has gone down a bit. I think we don't have too much of that happening, but we do have remote ICUs, people wanting to set up intensive care beds in their houses because they don't want to stay in hospital for a long time. That is still persisting, and elderly monitoring and care, because we work in a lot of communities where the children have gone to the cities or outside the country to work, and the elderly are living alone. So that is something that we still come across quite a lot. But yes, compared to the COVID days where we didn't have beds and people would be at home and we would be offering them remote monitoring, more because of the reason that they were in isolation, their relatives couldn't be staying with them, they didn't have any caregivers, so we were the only caregivers available on phone and on the web. But now, with COVID having gone down, relatives and friends also act as caregivers a lot, and then talk to the doctors through teleconsults off and on, instead of the doctor being there available, every day, morning and evening, to monitor the patient. So remote care has gone down a bit, but nothing else.
And what about the 16 hospitals that you mentioned? What about the rural population? What have been your initiatives in addressing the rural patients?
Yeah, so our teleconsults and digital health mostly works with rural patients. So we are working with the real Bharat, in contrast to most of the digital health companies and brick and mortar health companies that focus on tier 1 and cosmopolitan cities. So we have been working with the real Bharat for ever since we started, and it's the same with our digital health offering. And that is why we go where the community is, not just geographically but technologically also. So our digital health offering is very simple. It's just a one number call. So you can just call 88569 88569. You don't need a fancy app or internet connection. Any feature phone will do. So just call the number and we will be there to answer. So our ethos is zero waiting. A doctor is always available for you, whatever time you call. And that teleconsult is always free of cost. So you can talk to a GP, MBBS doctor any time of day or night for free, as many times as you want. But of course, if you want a super specialist consultation or some critical kind of help, then of course the GP will refer you to a super specialist where you may have to pay a little bit, not too much. So, uh, as I said, we are on feature phones. We are You can call, you can reach us out on WhatsApp. So we are always there on WhatsApp. We have a WhatsApp bot to take care of you, chats with doctors available on WhatsApp calls available. So we are where the community is. The entire community is on phone and WhatsApp in North India, and we are there to serve them at that very point.
Okay, that's also great to know. Another point I'd like to mention, there are two sectors which healthcare is, if I may say, today deeply connected: insurance and pharma. And without insurance and pharma, and if we see in terms of technology adoptions, both those sectors are very high on technology front. So, do you often see a challenge in terms of synchronization via technology for a hospital with insurance providers and the pharma?
I think that was the case 2 years earlier. 2 years earlier, we were having a lot of challenges because our mindset was very different. But in these last 2 years, I think all of us have embraced technology with a vengeance. I don't think even you would have been having this kind of an interview 2 years ago, right? It was unthinkable that you'll do an interview on a computer. You would have called me to your office, or we would have met at some conference or a seminar to do this interview. So everyone has embraced technology with a vengeance. So I think now it's much more comfortable for us. So especially see schemes like the Pradhan Mantri Jan Arogya Yojana, which we call as the Ayushman Bharat scheme colloquially. That insurance scheme is completely paperless and completely faceless. You do not need to go and deposit any file in any office. You do not need to meet any person to get that file moving or get a check released as payment. You just upload all the documents and the case sheets, and that gets processed, and the money is transferred to your account. The entire patient experience is also paperless. You do a biometric of the patient to identify the patient, and then you treat the patient. So schemes like this is the largest insurance scheme in the country now. More than 50 crore people are covered under it. uh, I don't think there any hospital, even the tiniest of hospitals in Kasbas who are impaneled with Ayushman Bharat, uh, get to do completely paperless experiences, deal with the patients, operate on the patients, get the payments done facelessly. So I think that is something that has democratized technology to a very large extent. And pharma, as I said, supply chains, pharma, consumables, these are all that we have worked a lot upon in the last 2 years during the pandemic. And we've seen efficiencies and margins grow exponentially, that we never had thought of earlier as well. Because when you apply technology and when you discover that your supply chains had been so dark and so opaque earlier, and now you're peeling off layers and finding newer things, going back and back and back into the supply chain, finding suppliers, then suppliers of suppliers, then their suppliers, finding the costs of goods, and then the cogs of cogs, and then further down. So you develop a lot of efficiencies into the system, and that can never be done without technology being incorporated deeply inside your system. So I think we've learned a lot there, and we are now much more comfortable with integrating with these two sides than what we were before about 2 years ago.
Sure. And lastly, I'd like to hear about your expansion plans in terms of predominantly right now you're focused in northern part of India, pan India expansion. What are the plans beyond those 16 hospitals in terms of including any other super specialty components or any other expand? So, what are the plans?
So right now we have 16 of our own hospitals, and as I said, two government hospitals that we are working with. The 17th hospital we will open very soon, in about I think 1.5 months, in Srinagar, Kashmir. That will be the fifth state that we will enter, and that is also a conscious decision because the hilly states, especially, have very low access to technology. We work a lot in Uttarakhand, and there we see access to care, access to technology, access to emergency care, especially, is very low. People have to come down to the plains to access good quality healthcare. So, Kashmir is something that we're looking to do. Other hospitals, Uttar Pradesh is something that we are very close to. It is a state that Amar Ujala, our largest shareholder, has a deep presence in. This is a state that my mother belonged to, so she was in Kanpur. So I have a lot of family there even now. So, and if you see the size of the state, Uttar Pradesh has a population which is larger than that of Brazil. And if you combine Uttar Pradesh and Uttarakhand, which was part of Uttar Pradesh earlier, they have a population which is larger than that of the USA. And you can see, compared to the USA, what kind of healthcare facilities we have in these two states for exactly the same number or a larger number of people living here. So I think we have a lot of opportunity in these northern states. Not for nothing are they called the Bimaru states, because their human development indices are amongst the lowest. In the recently released health index, Uttar Pradesh was amongst the lowest of the states in India. So there's a lot of things to be done in healthcare access. Uh, Madhya Pradesh, Bihar, Jharkhand, Chhattisgarh, Eastern Rajasthan, they are also not very well developed in terms of healthcare facilities. So I think we have more than enough on our plate in these northern Hindi speaking belt. But we are not saying that we will never go to South India, even though I feel that South India is much better served in terms of healthcare access, availability of doctors, availability of good government facilities. So I wouldn't say that we will never go there, but I think we have lots to do in North India before we think of traveling out of this geography. I think you're on mute, sir. Sorry.
Yeah, thanks. Before we end, I'd like to congratulate you on being selected for the Aspen Institute Fellowship Program. Can you briefly give a little detail to our viewers on that?
Yeah, I've just come back from the first week. So it's a 1 year fellowship program. The first week of trainings and learnings was held at Kenya. So I was in Kenya, and it was a week of many new things to me and forced me to look a lot inwards. So that was the very first time that I had been to Africa. So I consider myself a global citizen. I've traveled a lot. I've interacted with a lot of people. But then, you have these dark spots which you don't even think of. So I realized that, this whole huge continent of Africa, which is like one of the largest places in the world, in terms of both size and population, I had never stepped my foot on it. So that was something that forced me to rethink on what else I had missed out in life and what else I was completely not even thinking about. This was also the first time that for one full entire week I did not meet a single person of Indian origin. because I was the only Indian in that fellowship of 14 people that had been selected from around the world. And the entire faculty was also from the US. And usually you do find people of Indian origin scattered here and there, they are very common. And I've been out of the country a lot of times to various fellowships, conferences, seminars. So you do find Indians, or at least people of Indian origin, who've settled down in the
And in
US or
Kenya,
UK.
obviously, a
Yeah,
lot of
yeah, in Kenya as well. There's a large population of Indian
Indians.
origin people, but because of the COVID regulations and the fear of creating a super spreader event, the organizers were very careful that 14 people and around a similar number of faculty and facilitators flying from across the world into that. So they tried to keep us in one hotel as much as possible, that this is a bubble that we've created. You do your RT-PCR, you negative, enter the bubble, and then you stay there. So it was the first time that I spent an entire full week without meeting even one person of Indian origin, or speaking one word of Hindi. That was something, again, which I felt was something that in my 45 years of life, it was surprising that I have lived so much outside India, traveled so much, but in fact, I was living in a silo. It's like going to your comfort food. So whenever you have Indians around, you talk to them. You have Pakistanis around at least, so you have friends. You talk in your language. You eat the same food. But here, this was something that I did not have the luxury of. But again, I think that led to opening up more. That led to expressing more. I did not have to live in those role models or constrained environments, that I was a doctor coming from India, so I had to behave in this particular way. I could be whoever I wanted to be because nobody knew me, and it was a very new environment. So that was also something that forced me to look inwards and see what else had I not been doing or had not done, which was an important part of things, and how I could go out and do this sooner than later, rather than living in this whole comfortable cocoon of my life that I had been used to for these last 45 years. Yeah.
It's really exciting. Okay. Thanks a lot. Thank you for a very open and very, I would say, very interesting kind of discussion where you mentioned different facets. And as, yeah, in other times we might have this interaction in person, but during these times it was virtual. So thanks a lot again. Wishing you a good day. Thank you.
Thank you very much, sir. Thank you. Bye bye. Thank
Bye.
you. See you soon, hopefully.
Yes.